Welcome to this streamlined video where I've edited a lot of material out just to make sure the file fits onto Moodle. We're going to look at the anatomy of the shoulder joint and the rotator cuff, and then we're going to go through the different steps of the examination of the shoulder joint. I hope you find this presentation useful. So a quick overview of the anatomy of the shoulder joint. It's a capsular joint. And so you have the capsule of the glenohumeral joint. Around this you have various tendons that insert in and around the humerus and glenus. For example, the long head of biceps tendon comes over the capsule, and it can be palpable in the bicipital groove of the humerus. You also have the large rotator cuff tendon coming in that slides underneath the subacromial bursa and acromion above. You've got the acromioclavicular joint above and medial to the glenohumeral joint. Then you can follow the clavicle back down to the sternum, and that's actually where you do start your palpation, in the sternoclavicular joint. And not forgetting the scapula, which is usually viewed from the posterior approach, looking at the various borders of the scapula, inferior, medial and lateral borders. Now I've got a side view of the shoulder joint capsule. Here you can see again the supraspinatus tendon that sits below the acromion and bursa. You've got the synovial membrane, and because it's a synovial joint, that makes it more prone to arthritis, as we mentioned earlier. You can obviously get a tear of the labrum, and you can get what's called slap lesions, anterior posterior tears of the membrane. You can also see the biceps tendon comes in superiorly over the humerus and over the capsule of the glenohumeral joint. And then you've got the various rotator cuff compartments, the muscles around the joint itself, which we'll look at now. So now we're looking at the rotator cuff and what are the components that make up the large rotator cuff tendon. Anteriorly, you've got the subscapularis muscle that sits on the scapula. Remember, this is behind the large pectoris major, and so this muscle cannot really be seen. If it's wasted, it's difficult to notice. It's involved in internal rotation of the shoulder. Then posteriorly, you've got the supraspinatus muscle that becomes the large supraspinatus tendon that can be palpable around the humerus. This is involved in abduction of the shoulder. Then below the supraspinatus muscle, you have the infraspinatus muscle that is involved in external rotation of the shoulder. The teres minor and major, they're also involved with the infraspinatus. Below, again, you have a diagonal view of the shoulder with the long head of biceps coming in, the rotator cuff tendon coming in superiorly, that again just sits below the acromion and subacromial bursa. And this tendon glides to and from this point, and you can see that space is quite small that tendon goes through. So if you have any fraying of the tendon, if it gets a bit old and sort of smooth, then this can irritate the acromion and cause a subacromial bursitis. You can also get calcification of this tendon, particularly the supraspinatus tendon, and this too is a rough surface. This again aggravates the subacromial bursa, and because it's a narrow space that it's gliding in and out of, quite easily causes inflammation and pain. Just to recap, which rotator cuff muscle is raised, so which shoulder movement. In abduction, the first 15 degrees are all supraspinatus, and then the anterior deltoid muscle kicks in and is activated to help abduct further beyond this. In terms of external rotation of the shoulder, the infraspinatus muscle of the rotator cuff is involved. And the subscapularis muscle, as we said earlier, is involved in internal rotation of the shoulder. Now, there's a danger that we can oversimplify the movements of the rotator cuff and not really understand the complexity of the shoulder joint. The shoulder joint is a multi-axle. That means it moves in all planes. A ball and socket joint, the humerus and the glenoid, and a synovial joint too. So it's got a capsule with fluid inside, and so it's a very complicated joint. It's got a far-reaching range of movement. If you think about all the daily activities you involved in and how you use your shoulder from the moment you get up to get dressed, comb your hair, reaching for things in the cupboard, all these activities involve quite complicated mechanical use of your shoulder. And so if you have a problem with your shoulder, immediately you have a lot of difficulties in your daily tasks. The shoulder joint is less stable than the hip joint, as the socket is quite shallow. The glenoid does not go fully round the humerus, which allows it to be more free and to have a greater range of movement. But because of that, it's more prone to dislocation. The scapula, the posterior part of the shoulder joint, is highly mobile, and it can glide in and out, tilt upwards and downwards and around the thorax, allowing you to change the position and orientation of the socket. Which means if there's any shoulder weakness due to a tendon tear or a nerve palsy, the scapula can compensate, and thus you get these really abnormal scapular movements, just to allow the person to do the movement they need to do. And part of the examination of shoulder is looking behind and watching the scapula move back and forth, looking for any abnormal movements, give you a hint, a clue as to maybe a nerve palsy, like a thoracic long nerve palsy, or a problem of a tear of maybe the rotator cuff. As we briefly mentioned, each movement of the shoulder, there are several groups of muscles that are activated to make that movement possible. And because of that, it's quite hard to isolate one muscle and its tendon to examine to see if it's that problem, that muscle. For example, in arm abduction, the first 15 degrees of arm abduction is achieved by the supraspinatus muscle. That continues to be activated, but then abduction continues with the deltoid muscle, which is a big, powerful muscle, a big, powerful abductor of the shoulder. And so if there is a supraspinatus problem, often the deltoid just kicks in and does the majority of the abduction to compensate. And finally, the last part of the abduction, right up moving the arm next to the head, is the trapezius and serratus anterior muscles that are activated. And so when, for example, looking at examining the supraspinatus muscle, it's possibly best just to keep that 15 degrees or less abducted, so that you're not examining the deltoid, for example, when you're checking for resistance testing and any weakness. So now we get into the bones of the examination, and as with any examination, first of all, we want to gain consent from the patient, explain what you're going to do, you're going to wash your hands, maintain privacy, and get a chaperone if necessary. Then you need to expose both the shoulders, because you're going to look from the front, the side, and the back of the shoulders. And when you're doing inspection, you're looking for any deformities. You're going to contrast and compare the left to the right. You're going to first of all look at the bony contours of the shoulder. Can you see any possible dislocation of the AC joints anteriorly? There may be a disruption of the clavicle, and therefore a disruption of the AC joint too. You're going to also look at the humerus areas to see whether there's any possible swelling there. When you look from the side, you're looking particularly at the glenohumeral joint to see whether there's any dislocation. Note it's easier to see an anterior dislocation than a posterior dislocation. Often you can't decide whether someone's got posterior dislocation until you palpate and examine in more depth. You're also just looking at the bony joints to see if there's any swellings. Again, you may see swelling over the upper arm if there's been a humeral fracture or inflammation. And also you're going to be looking for muscle wasting. Remember, you can't see subscapularis wasting anteriorly because it sits behind the pectoris major. You can see the deltoid bulk, usually quite clearly, and see whether there's any loss comparing to both sides. And posteriorly, obviously you can look at the supraspinatus and infraspinatus muscles, and they can be wasting due to tendon tear. And so again, you're going to compare left to right, see if there's any muscle wasting. And finally, when you're looking posterior, also looking for any scapular winging. If you suspect there's any scapular winging, the scapula coming towards you, then you will ask the patient to put their hands against the wall and press into the wall to augment any possible winging. And that's usually secondary to paralysis of the serratus anterior nerve. This can happen with gymnasts or just happen incidentally, or people doing other extreme sports too. Here we have an example of what happens normally with the scapula. When a patient lifts up their arms, you see the external rotation of the scapula. And usually the red spot doesn't come out that prominently. You do see it move, but it usually doesn't move that far laterally. However, when we've got a problem with the nerve supply to the scapula, or perhaps there's a problem with the rotator cuff, there's a weakness, then the scapula does abnormal movements and maybe becomes more prominent, as you see in the photo on the right hand side. As the patient pushes against the wall, the right scapula becomes more prominent, becomes more anterior, and that's what we mean by winging of the scapula. The second part of the examination of the shoulder is palpation. And you move your fingers along a journey. You start in the middle, in the midline with the sternoclavicular joint medially, and then you palpate along the clavicle laterally until you come to the AC joint, the acromoclavicular joint. And you're assessing whether there's any tenderness, is there any pain as you do that. Also the mobility of the clavicle, and so you also may at the same time be testing the AC joint, the architecture of that joint as you press, because the ligaments can also be lax and cause laxity when you press along the clavicle. When you get to the AC joint, you palpate the acromion, and then you come down inferiorly and medially to the coracoid. So that's about 2 centimeters below and medial to the tip of the clavicle. We'll look at that on the next slide. Then you move around laterally till you come to the glenohumeral joint, and you may go around anteriorly and posteriorly, and then you palpate along the humerus to the bicipital groove to palpate the biceps tendon. Now, if you're not sure where to locate this, particularly in a big shoulder, you ask the patient to clench their biceps. So they flex their elbow and then squeeze their fist, clench the biceps, and you can feel the tendon tighten up. Then you want to go, still holding your hand in that position, you want to ask the patient to extend the shoulder to bring the supraspinatus anterior to the acromion and palpate the supraspinatus. So that's, again, you put your fingers are over the humerus, and as you may just put your finger tips across this area, and as the patient extends their shoulder, as it moves their arm behind them, this will bring the supraspinatus anterior to the acromion. You can palpate for any tenderness, any impingement. Again, if you can't really feel or palpate the supraspinatus tendon, then it may be a tear. Also, when we talk about impingement, we mean the tendon's getting stuck, it's impinging in an area just below the acromion. There's also a supracromial bursa, and that can be due to several reasons. One of them is calcific tendonitis. You get calcification of the tendon, makes it hard and rough, and that rubs against the supracromial bursa and causes pain or impingement too. Then you go back down to the back of the shoulder, around to the back, and then you're going to palpate and check all the borders of the scapula, superior, medially and laterally, again for any tenderness along those borders. So these are the landmarks. Just remember, we started at the sternoclavicular joint. We followed where the two dotted lines are along the clavicle to the acromioclavicular joint, and then you go down 2 centimeters to the coracoid process, and that bulge there on the picture on the left. And then you come to the glenohumeral joint. You start below in the axilla, going around the glenohumeral joint, and then come back to the bicipital groove. And here we have a picture on the right of the anatomy. You see the different tendons and ligaments around the AC joint. They can become disrupted in a dislocation of the AC joint, or fracture again can disrupt this joint, and you get a gap between the acromion and the coracoid process. In this slide, I'm just highlighting how you palpate the supraspinatus tendon. So you just extend the shoulder backwards, and you put your left hand, if it's the right shoulder, over the supraspinatus tendon. You're palpating for any tenderness, any lack of tendon, whether it could be a tear or lack of movement. And yeah, again, for impingement, this is where you'll feel the place where the supraspinatus tendon is impinging as it moves. Now we come to the third part of the examination of the shoulder, active and passive movements of the shoulder. Remember, active movements is when the patient is doing this movement for you, and passive is when you are moving the shoulder yourself. It's passive, the shoulder is moved by yourself. So in active movements, I'll get the patient to abduct with their arms relaxed by their sides. I'll get them to move both shoulders away from the body, right up to the top of the range of movement to the top of the head. Abduction, when I ask them to cross the arms across the body at the front, and an X kind of formation. Remember, I'm looking at both shoulders. I'm asking them to move both at the same time to compare and contrast where there's restriction of movement and where there may be pain or a problem on one side. Flexion, I'll ask them again just to relax their arms by the side, and with their thumbs pointing towards the floor, ask them just to lift the shoulders up, right up to the head. And then again, I'll keep their arms stretched and extended, ask them to move their shoulders backwards, so the hands are going behind their body, again both sides. With external rotation, I'll ask them to lock their elbows into their side, keep their elbows locked in that position and flexed, and ask them to move their arms out to the side, and usually demonstrate this in front of them and ask them to copy what I'm doing. Internal rotation, again, keep their elbows locked in, asking them to put their hands onto the stomach and kind of move right internally across their stomach. Or you can ask them to put their hands behind their back, with the hands behind the back, and asking how far they can reach up their back with the hand internally rotated. So there are two screening tests that we do when examining the shoulder. We ask the patient first of all to put their hands behind their head. So this is a combination movement of abduction, internal rotation, and see whether there's any pain or any restricted movement on either side. And then we ask the patient to put their hands behind the back, as far as up the back as they can. Again, this is just screening to see if there's any pain and a reduced movement in either shoulder. And if there is, then we can go on to more focus on a more full examination on that affected shoulder. So now we're going to go on to the passive movements of the shoulder, where we take over the movements of the shoulder. Again, we ask the patient to do what we did before, but where they may have been restricted movement, we may just extend that restricted movement to see if there's any pain, what's causing the restriction. Again, always asking permission, asking if there's any pain in the shoulder before we start. And we just want to feel the movement, feel whether it's a smooth movement, whether there's kind of resistance to when we're moving. We talk about a soft versus a hard shoulder. You know, is it easy to move it? Is it just because there's weakness that we can easily move it, or whether there's actually impingement and there's resistance to our movement because of pain or impingement? In a frozen shoulder, you can feel the joint. It feels quite tight, and you feel like it's like a cogwheel, because the whole capsule is contracted. And so it's hard to do any movements. It feels quite stiff. When we're doing the passive movements, when particularly we're looking at extension of the shoulder, then maybe they can get up to about 90 degrees, but not higher. Then we're going to fully extend the shoulder to 180 degrees and see whether there's any pain when we're doing that. That's a positive test. This is near sign, and this is looking particularly impingement in the subacromial space, whether it be a calcified tendon, whether the subacromial bursa is inflamed, what we call subacromial bursitis, or whether there's a tendonitis causing that problem. So that's near sign. Again, we might have noticed in the initial active movements that the patient seems to be in pain when they abduct their shoulder. Now, we call the painful arc that pain that develops at about 60 degrees to 120 degrees. And this is particularly the range of movement where the subacromial space is narrowed. And this is due to the tendon movement and the bursa, and this is where you get rubbing of the supraspinatus tendon or the rotator cuff against the subacromial bursa, causing pain or impingement. And then beyond 120 degrees, that whole space is opened up again. So you get no pain between 0 and 60, 120 and 180, but the painful arc is between 60 and 120. Now, the patient may stop movement about 60 degrees. And if you ask them to get to 120, or you passively move the shoulder into 120 to 180, you may notice that they're pain-free again. So that's where you come in as useful as an examiner in the passive movements to see whether they have a painful arc if the patient's resisting doing the full range of movement. Now, once you've got the patient in full abduction, perhaps at 180 degrees, what you can do is ask the patient to lower the arm slowly, not just drop it down quickly, and see whether they experience pain. And that's a positive sign. This is the drop test. So we ask them to just slowly drop the arm. Or you may find there's no pain, but as they try and slowly reduce adduct the arm downwards, suddenly there's weakness in the rotator cuff, and the patient cannot hold the arm in slow movement, and it suddenly just drops in a dramatic fashion, and that's because there's a tendon tear. So looking for the drop test, you're looking first of all, is the pain as they begin to adduct the arm down, or suddenly there may be suddenly dropping of the arm. They cannot hold the arm in that slow motion because they've got a weakness in the rotator cuff. Another thing we're just looking for is deltoid power. So we ask the. Now we're going to look at testing the different components of the rotator cuff. So here's a picture of near sign again. In this picture, the exact Hawkins-Kennedy test. The shoulder is placed. Gerber's lift-off test. So the best test for testing for biceps tendonitis is. This is the final test we're going to look at, called the scarf test, for obvious reasons. This test we're screening for osteoarthritis and also rheumatoid arthritis of the glenohumeral joint. We flex the shoulder and the elbow, stabilize the scapula with our other hand, and if it's the right shoulder, we wrap our hand around the right elbow and move the shoulder and wrap the arm around the neck like a scarf to see whether there's any pain or stiffness, and that's a positive test, possibly linked to osteoarthritis of the glenohumeral joint. I hope you found this presentation useful. The last slide, I listed a few resources if you want to find out more. Thank you for listening.